Okay, this will be hopefully the final part of the antibiotics, and we're going to talk about a very potent group called aminoglycosides. They have a very serious toxicity, so they're only really saved for severe infections. Bactericidal, meaning they are definitely killers, and interestingly enough, these kill mostly gram-negative. A lot of our other drugs killed more gram-positive than gram-negative. Pseudomonas, E. coli, Proteus, Klebsiella, Serratia, those are just some of the ones that they kill. This is often used in combination with other antibiotics for synergistic effects. Now, I know you remember what synergy means. It means the drug interactions in which the effect or combination of two or more drugs with similar actions is greater than the sum of the individual effects of the same drug, meaning they're just stronger together. So they're often given with penicillin, cephalosporins, and vancomycin. Certain gram-positive infections are resistant, that are resistant to other antibiotics, they will also give aminoglycosides for. So one of the most important things to know about aminoglycosides is that they have severe toxicities. Ototoxicity is our ear. Temporary or permanent hearing loss, and which can also mean we know that our vestibular columns in the ear can cause all kinds of balance problems. And then nephrotoxicity would be our kidney. Varying degrees of reduced renal function. Rising serum creatinine may indicate reduced creatinine clearance, and we know our blood urea nitrogen, or referred to as a BUN, and creatinine are indicators of kidney function. So we would definitely be tracking that while giving these drugs. So what we're going to do is we're going to monitor trough levels every 3 days while on therapy or as ordered. Remember how we talked about the trough and peak levels of these drugs? Well, we have to watch these very, very carefully because we need them in that margin between the trough and the peak. Otherwise, we're going to have hearing and possibly kidney issues. And what do you suppose a peak level in this one is for? What do you suppose we're looking at? It means it must be high enough to kill the bacteria, and the trough level must be low enough to minimize toxicity. So with these drugs, the peak level must be high enough, the peak of the drug, to kill the bacteria. And again, these come in for really, really high level infections. And the trough level must be low enough to minimize toxicity. And here's a group of aminoglycosides. You know what? I'd like to see most of them are CINs, CIN, but that we do have some other ones. But a lot of the ones that end in CIN are aminoglycosides. Gentamicin, origaramicin, kanamycin, neomycin, streptomycin, and you can read the rest. All of these are given parenterally or IV. They have very, very poor absorption orally. So there's no PO forms. I'm sorry, except I always forget about neomycin because I don't give it that much in what I do. But neomycin is the one given orally to decontaminate the GI tract, usually before a surgical procedure. But it's the only one out of the whole group. The rest of them are known just to be given IV. It's also used for an enema for this purpose. And again, I bolded it. You guys will probably see this again on a test. So all of these can cause ototoxicity and nephrotoxicity, which is the ear and the kidney, and they must be monitored extremely closely. So what are some nursing implications for aminoglycosides? We have to monitor that peak and trough blood levels of these drugs to prevent the kidney or the ear toxicities. Symptoms of ototoxicity include ringing in the ears, or another, as it's referred to as tinnitus, dizziness, and hearing loss. Symptoms of nephrotoxicity or the kidney include urinary casts, protein in the urine, increased BUN, which I talked about, blood urea nitrogen, and creatinine levels give us numbers that directly relate to how the kidney is functioning. Okay, now we're going to move from the aminoglycosides to our fluoroquinolones, also just known as quinolones. Excellent oral absorption, unlike our aminoglycosides. It's reduced by antacids, so we have to be careful about that. Effective against gram-negative and some gram-positive organisms, usually against protozoas, bacterioides, Flagellus, and C. difficile. And I bolded C. difficile because that's a very, very bold bacteria that we see in the hospital that Usually very compromised patients or the elderly have it. Very, very difficult to treat. It's another one that's also bactericidal. Lower respiratory infections would be like way down in the alveoli or the deep bronchus. Bone and joint infections, again, deep infections. UTIs that probably the sulfurs can't help. Infectious diarrhea, that's where a lot of times we find the C. difficile. Skin infections, STDs, and anthrax. Let's see. These pose a risk, the quinolones, for phototoxicity, just like our sulfas, so they have to avoid sunlight, and should use protective clothing when outside with sunscreen and sunglasses. And then here's a list of our quinolones. And again, a lot of these end in CIN also. Ciprofloxacin, Cipro is very, very common. Out of all of these, it's used more than anything. And Levaquin too. But then you've got your norfloxacin, gadafloxacin, moxifloxacin, and gemifloxacin. But out of all of them, the ones we see more than not are Cipro and Levaquin for our quinolones. Some other antibiotics that are just in their own groups: clindamycin or Cleocin, again, gram-positive anaerobic infections, chronic bone infections, genital urinary tract problems, intra-abdominal infections, may cause pseudomembranous colitis, so can be very, very rough on the GI tracts, what they're saying. That's colitis is inflammation of the colon. Dapsone, old drug. We've been using it for leprosy for like over 50 years. Pneumonia associated with AIDS, so very heavy-duty type pneumonia, and HIV and other uses. And then Zyvox is used to treat vancomycin-resistant enterococcus, or MRSA. May cause hypotension, serotonin syndrome. And serotonin, if we don't have enough serotonin in our body, we're very, very depressed. Serotonin makes us feel happy. So they can be very depressed on this Zyvox. Other antibiotics, nitrofurantoin or microdantin, is probably primarily used for UTIs, urinary tract infections. Again, there's your E. coli, Staph aureus, Klebsiella, Enterobacter. Use careful if renal function's impaired. This drug concentrates in the urine, so again, we're going to try the sulfurs first. Usually well tolerated if the patient's kept hydrated. Vancomycin is the drug of choice for MRSA or methylo-resistant Staph aureus. Again, resistant to everything. We must monitor blood levels to ensure therapeutic levels and prevent toxicity. And again, I bolded it, reserved only for very serious infections. This is another one that may cause ototoxicity and nephrotoxicity. Should be infused over an hour. A lot of drugs go in 20 minutes or 40 minutes, not this one. You have to monitor the IV site very closely in case it slips out. It can hurt the tissue. And this one's also known that it may have a side effect is red man syndrome, which is flushing, itching of the face, head, neck, and upper trunk. That's why they call it red man. Antihistamines may be ordered to reduce these effects. And again, ensure adequate hydration, 2 liters in 24 hours. So that's just like the sulfonamides. Nursing implication, again, for any antibiotics, very essential to obtain cultures from appropriate sites before beginning antibiotic therapy, because we want to know what organism we're going after. Patients and our patient education for antibiotics need to be instructed to take antibiotics exactly as prescribed and for the length of time prescribed. They should never stop taking the medication because they're feeling better, because all that means, especially with our bacteriostatic microbes, is that we're keeping them at bay, but if you stop taking the antibiotic, then the infection will come back. So if they're on a 5-day regime of antibiotics every 6 hours, they need to make sure they take it every 6 hours. If they're on a 10-day regime of antibiotics every 4 hours, they need to make sure they take it every 4 hours, unless they're sleeping, is usually what we teach. Before beginning therapy, assess drug allergies, renal, liver, and cardiac function, other lab studies. Be sure to obtain thorough patient health history, including immune status, because we want to make sure they, we need to know about their allergies. Assess for conditions that may be contraindicated to antibiotic use, which, it's like I've always told you, pregnancy is everything is contraindicated for pregnancy, although they can take a lot of antibiotics and it's safe. Assess for potential drug interactions. For safety reasons, check the name of the medication at least 3 times before you give it. As you can see in this PowerPoint, and it's like one of the first ones for medicines, and there's a reason why I do that, is because you can see a lot of them that start with CEF. I mean, there's tons of them. And then you notice in the different families, erythromycins, they all end in CIN, but some of the aminoglycosides end in CIN. So a lot of them sound alike and they look alike, have similar spellings. So we have to be very, very vigilant so that we don't hurt somebody. And we just absolutely do not want to give the wrong medication to somebody. And then I bolded this. This is another nursing implication, and it's an area for teaching. Antibiotics may decrease the efficacy of oral contraceptives, meaning they make it not work. And I mean, that can really, really upset a lot of people if they don't know that and they're taking an antibiotic and all of a sudden their birth control pills don't work. And then finally, monitor for therapeutic effects, and that means, did it work? Improvement of signs and symptoms of infection. We want them to return to normal vital signs, no temperatures. We want them to have negative culture and sensitivity tests, meaning the antibiotic worked. The culture is negative for bacteria. We want the fever to go away, the lethargy, where they just had no energy and they felt very achy. Drainage, if there's drainage, and redness, swelling, all of that. We just want it all to go away. And then finally, a monitor for adverse reactions. Okay, this will conclude our teaching for now anyway on antibiotics, and I will see you next time in class. Hope you have a great evening or afternoon or morning, whenever you're listening to this. I'll talk to you soon.